Sorry. Yeah, I believe we can start. We have quorum, I think, as we do the introductions, I believe we'll have more and more people coming in. So thank you so much, everyone, for joining, for those that are participating, for our presenters. We are very grateful that you accepted to present and to share in this very important topic. Our topic today is understanding event-driven PrEP and how countries can reap maximum benefits. To those that are joining us as participants, we have different language options. So I think on the icon that's a globe, just choose your preferred language, English, French, or Portuguese. We will be having various presenters, so kindly use the Q&A box at the bottom of your screen and write your question indicating the panelists that you would prefer to respond to your questions. Otherwise, we will get started. As I mentioned, our topic is understanding event-driven PrEP, and this has come about because of interests from some of the countries that are under the South to South Learning Network. And we thought that this is an area that countries can benefit from. And we researched, asked a few countries to present on their country experiences, and also invited WHO so that they could also share the recommendations and guidance and give a little bit more understanding, give us a little bit more insight and understanding around event-driven PrEP, because we are in the era of the HIV prevention roadmap. We are looking at 2025, which is less than the end of the prevention roadmap is less than 2 years away. And yet there's a recommendation that countries adopt a people-centered precision prevention approach that focuses on key and priority populations in order to develop their national prevention targets. And the focus of key and priority populations that can benefit from this, some of these prevention programs, prevention strategies is very key. Looking at the rapid introduction also of new prevention technologies, which is also step 8 of the HIV prevention roadmap. So we, in the interest of achieving those targets, it's important that countries understand some of the recommendations that are being made so that we can be able to scale up and reach some of these priority populations in order to achieve the HIV prevention targets. So without further ado, I will introduce our panelists, and we have first Michelle Rodolphe, who is the technical lead on ARV-based prevention with the testing and prevention and populations team of the WHO, HIV, hepatitis, and STI department. And her focus is on future prevention products, PrEP delivery for women, and integration of HIV prevention into the SRH program. So she'll be taking us through the first presentation on ED PrEP to help us understand it a little bit better. Then we have Jacqueline Piena, and I hope I've pronounced that right. She's a qualified psychologist and public health specialist with extensive experience in conceptualizing and implementing large public health interventions and programs. She has been managing national clinical trials in ARV and TB drug safety and HIV microbicide and PrEP trials. She has served the US government in the capacity of both CDC VMMC lead and USAID biomedical prevention specialists. She is currently the technical director at Arum Institute, leading programs providing comprehensive services to key populations across South Africa. She will be sharing with us the Arum experience in implementation of ED PrEP. We also have Featherstone Manguje from FHI 360, the Mosaic project, who will be also taking us through the Zambia's experience with ED PrEP and the considerations that they are making in terms of rolling out ED PrEP. So welcome so much our presenters. We are very grateful that you could make it to join us, and welcome all those that are joining. Again, just repeating the rules of the road. Kindly choose your language of preference, English, French, or Portuguese. We have translators that are going to be able to support you. Then put your questions on the question and answer box, indicating the panelists that you would like to respond to your specific questions. Welcome so much. We'd also appreciate on the comment section, if you have a comment, you can indicate it there. If you have an idea of any future learning topics around PrEP that you would like to see as hosts, you can also indicate it there. Otherwise, I want to pass the mic over to Michelle to give us some opening remarks and also give us a bit of understanding around event-driven PrEP and why WHO has given this recommendation. Welcome, Michelle.
Thanks so much, Lucy. So if you could just, excellent. Thanks for just going to, oops, let's go back. Okay, super, let's just start there. So thank you to the Cell Cells Learning Network for inviting WHO to speak on event-driven PrEP. The bulk of my presentation will focus on event-driven PrEP, but I also want to contextualize it in the framework of updated WHO guidance on pre-exposure prophylaxis. I also want to just give my thanks in advance to my colleagues, Heather Marie Schmidt, and, okay, it says, sorry, I think my camera is on. Sorry, I just got a message to turn on my camera. So I hope it's on. Anyway, and I'm just going to turn off the chat preview so it doesn't get, so let me just go ahead. I just want to give thanks in advance to my colleagues, Heather Marie Schmidt, who is a joint WHO, UNAIDS, PrEP Regional Advisor in Asia Pacific, and Rachel Bagley, and thank you to Heather Marie Schmidt who prepared these slides. So just moving to the next slide. And just for those in the audience, I've got some notes on a screen next to me, so I'm not looking direct. It looks like I've got my videos are not linked up, so you may not see me correctly. So again, apologies. So WHO's recommendation on oral PrEP for HIV prevention. So just really to outline, pre-exposure prophylaxis is the use of ARVs before potential exposure to prevent HIV acquisition. High levels of uptake as part of combination prevention have been associated with population decreases in new HIV diagnosis in countries with concentrated epidemics among previously used concentrated epidemics among more general population, and epidemics and focused epidemics. So WHO has recommended PrEP for all individuals at substantial risk of HIV since 2015. This is high quality evidence from clinical trials, including open label extension studies and real world implementation for oral PrEP. Oral PrEP is highly effective when used as directive, and the effectiveness is correlated with adherence. PrEP is not protective against HIVs or other STIs. It is not protective against other STIs or pregnancy. And large scale uptake as part of combination prevention has been associated with population level decreases in new HIV diagnoses. Next slide, please. PrEP can be empowering. It has psychological benefits, including reduced shame and fear, and it is an additional prevention option in filling the prevention gap. It's also a very important HIV preventative tool featured in the Political Declaration 2021 and the Global AIDS Strategy, and it is integral to reaching the global 95% target for a comprehensive prevention for 2025. Next slide, please. So just a little bit of background. I'm just showing a slide here on the number of people who've received oral PrEP at least once in a year. And this is data from 2021 that shows that even in the year 2021, there was 1.8 million PrEP users, even despite COVID interruptions. The map here gives you an overview of the regions and countries that have the number of PrEP users. You'll see the biggest numbers are in the United States of America, South Africa, Kenya, and Nigeria, followed by Brazil and Australia. And then you can also see other countries, for example, in lower Latin America and across Southeast Asia, where the numbers are not as high. But we see in the bar graph on the left, the numbers have been increasing over the last 9 years. Next slide, please. So here is just it's a timeline of the WHO PrEP recommendations and guidance. So WHO came out with our first recommendation on PrEP for serodiscordant couples, men of 6 men, and transgender women in 2012. In 2015, we came out with the inclusive recommendation for all people at substantial risk. And I want people to highlight the recommendation 2019. This is when WHO came out with our recommendation on event-driven PrEP, also known as 211, which I'll speak about in more details today. And I will also touch on the guidance, the update to the WHO recommendation on the 211 or event-driven ED PrEP in 2022, just last year. It was released at the Montreal conference at IAS, where we updated our original recommendation to be more inclusive, to include all men and all men, but to be very specific, all people assigned male at birth who are not taking gender-affirming hormones, in particular exogenous estradiol. So that I'll speak about in more detail later in my presentation. Next slide, please. So with the document from 2022, the differentiated and simplified PrEP for HIV prevention, in this document released last year, we updated our guidance on starting PrEP, stopping PrEP, and event-driven PrEP. So starting and stopping PrEP for all populations, and we updated our guidance for event-driven PrEP to be more inclusive of all men. And when I say all men, I'm meaning, and to use general language, gay men, homosexual men, straight men, heterosexual men, people who were born men and identify as men and are not taking gender-affirming hormones, people who were born men and do not identify as men and are not taking gender-affirming hormones. So if there's more questions about this, I'm happy to either address this in the Q&A or respond in the chat. We also updated our guidance on kidney function monitoring, HIV self-testing, and differentiated service delivery models and viral hepatitis. And the focus of this technical brief is on oral PrEP. However, guidance on long-acting injectable cabotegravir and dapivir as relevant. So I just go, somebody has to do my slides, apologies. Next slide, please. So starting, using, and stopping TDF-based oral PrEP and event-driven PrEP dosing. So really, this slide here is key. So the new recommendation is for cisgender men, and I can't see it. That you should, if you have full screen, you should be able to see at the bottom of the slide. It's going to exit full screen so I can see. Oh no, I guess it didn't show up. There should be some asterisks at the bottom that just define cisgender men. So event-driven PrEP is for cisgender men with sexual exposure, irrespective of the gender of the partner. So assigned male at birth, having sex with men, women, queer people, or trans people, for example. So, and this includes gay, bisexual, and heterosexual men. So for all men, and so when I say men, I'm just going to refer to all people assigned male at birth, just for the ease of for language. So for starting, using, and stopping TDF-based oral PrEP, the event-driven PrEP dosing is a double dose, 2 to 24 hours before sexual exposure, using 1 dose per day. And then for stopping is 1 dose per day until 2 days after last sexual exposure. This also applies to transgender women from other trans and gender diverse people assigned at male at birth who have sexual exposure and are not taking gender affirming hormones. And when I say gender affirming hormones, specifically it's exogenous estradiol based hormones. But for this presentation, I'll use gender affirming hormones as I move forward. Next slide, please. So here's a graphic just that helps to show for how to take ED PrEP. So you see here on the left side of your screen that you start day 1, 2 to 24 hours before exposure, with taking 2 pills and followed by 1 pill a day. And then 1 pill a day. And then after the last sexual exposure, you continue 1 pill a day for 2 days. So individuals eligible for the event-driven PrEP dosing start and stop PrEP using the same approach, whether they intend to use PrEP every day or for one event or multiple events. And I'll get into this a little bit in more detail further on in my presentation. Next slide, please. So this really the key point about this slide is that what is the changes from what we used to say? Broader eligibility. Previously, WHO only recommended event-driven PrEP for men who have sex with men and trans women having sex with men, but not taking gender-affirming hormones. There's research to indicate that event-driven PrEP is not effective in trans women taking gender-affirming hormones. Event-driven PrEP remains only for sexual exposure, not for parenteral exposure, for example, for people who inject drugs. And just to say, we've expanded the eligibility for event-driven PrEP to all men, no longer just for MSM. And also to really emphasize that hepatitis B infection is no longer a contraindication for oral event-driven PrEP dosing. However, if somebody has hepatitis B infection, to treat the hepatitis B, daily TDF is the recommended regimen for treating the hepatitis B. So if there's questions about this, we can get into it a bit later, but I just really want to emphasize hepatitis B infection is not a contraindication for oral event-driven PrEP dosing. Someone can do use event-driven PrEP dosing. It means that they're protected against HIV, but not treating their hepatitis B. And all men, gay men, straight men, bi men, queer men, who are not using, not trans men, I want to be clear here, and men who are not using gender-affirming hormones can use event-driven PrEP. Next slide, please. So starting, using, and stopping oral PrEP for daily dosing. So I want to emphasize here, I'm just making sure that I see my slide clearly, that WHO used to have much stricter requirements for starting and stopping oral PrEP. Now for all people, cis women, cis men using daily PrEP, we recommend, so just, okay, let me backtrack here to make sure I'm clear, because I think this can get confusing. But now for all cis women and trans and gender diverse people assigned female at birth, cis transgender women taking gender affirming hormones, we recommend before oral PrEP is effective to use 7 days, to take 1 dose daily for 7 days. This is daily PrEP. 1 dose per day while having potential exposure to HIV, and then for stopping 1 dose per day for 7 days after the last exposure. Previously, we said 1 dose per day for 21 days. This has been simplified so that the starting and stopping are both 7 days for daily PrEP. And this is for people, just bear with me here. People assigned female at birth, then 7 days start, 7 days stop. And when I go to the next slide, you'll understand why this is really for women and people using oral PrEP for drug use. So next slide, please. But what I think, but let's go, okay. So other key messages. PrEP is part of a service. PrEP is a service that needs to be flexible to the needs and preferences of clients. Regular HIV testing is required before and after use. WHO now recommends that HIV self-testing can be used to complement existing testing strategies, and HIV self-testing may be preferred for convenience, privacy, and self-managed care. And self-testing can reduce clinic visits. We've also simplified our kidney functioning requirements. It may be required within 1 to 3 months of initiation, depending on age and comorbidities. And testing for hepatitis B and C is not required, but encouraged within 1 to 3 months of initiation. And we encourage regular testing for STIs. Next slide, please. And then just in speaking about differentiated service delivery, support, scale up, access, and acceptability, it's really important to talk about to emphasize having a person and community-centered approach to support making more services more accessible and acceptable, and that having a differentiated PrEP service delivery approach, this may improve uptake, persistence, and effective use. The differentiated service delivery building blocks shown here on the right provide a framework for initiation, follow-up, reinitiation, and switching between PrEP products. It's important to understand what do men need and value from a service. Next slide, please. Differentiated services for PrEP. Differentiated services for PrEP for men. What are the options? Where? The service location is important to reach men. We have to consider having service providers that are acceptable and accessible to reach men. When service frequency, that services should be available at times that are acceptable and accessible for the men reaching these services. And the service package should be a package that addresses what men need. And then we're almost done here. So the next slide, please. I do just want to emphasize that offering choice in PrEP products may increase demand, uptake, and effective use of HIV prevention. Just a plug here for the WHO recommendation on long-acting injectable cabotegravir that came out last year, at the same time as our recommended DSD and simplified PrEP recommendations. WHO also says that long-acting injectable CAB may be offered as an additional prevention choice for people at substantial risk. I know this conversation is not about injectable CAB, but I do want to just share this with the group. We can address this in a separate venue, perhaps. Next slide, please. And just offering choice in PrEP products, just to really emphasize that by offering choice, it expands people's access to prevention. What we know about CAB is it's highly efficacious, it has a good safety profile, and it's in discrete choice experiments, we found that it's often considered acceptable in communities, and for some may be preferred to oral PrEP. Choice is critical. And it's very important to support CAB-LA as an additional option for PrEP alongside oral PrEP, and for women, Depivrin vaginal ring and other prevention choices. And really just to end this presentation by saying we need implementation science to fill these gaps. And then we'll just go to my final slide. That when we're considering when to provide PrEP, what things to consider when providing PrEP to men, just that it's very important that product choice contributes to scale up, uptake, persistence, and effective use, and that we don't forget to address stigma, discrimination, and criminalization, and how important it is to create an enabling environment so that people can access choice and access prevention. And so just with my last slide, I'd like to thank my colleagues. So over to my next slide, please. Next slide, please. Just want to thank my colleagues from WHO, my colleagues from WHO and UNAIDS, and just everyone who contributed to the technical brief. they're all listed in the acknowledgements of the document. With that, I say thank you very much. Over to the moderator.
Yeah, thank you. Thank you so much, Michelle, for helping us understand the difference between the oral daily PrEP and the event-driven PrEP, as well as who it is targeted at, and the benefits and risks. Now, moving on, I'll invite Jacqueline from Arun to take us through the country experience for South Africa in implementing ED-PrEP. Welcome, Jacqueline.
Thank you, Lucy. Good morning, colleagues, and good afternoon to other colleagues across the continent and across the globe. Colleagues, I'll be presenting on our experiences of implementing event-driven PrEP amongst men who have sex with men and eligible transgender women in South Africa across 5 districts. My co-presenter, Helen Sava from CDC, unfortunately couldn't make it. Next slide, please. Sorry, so the background as it relates to South Africa is that we've got quite a very substantial prevalence of HIV in South Africa, as most people are aware. We also have a very high prevalence of HIV amongst men who have sex with men in the country, with reports and research having indicated it being as high as 44% in Johannesburg, which is a very large metropolitan area within the Gauteng province. And UNAIDS had pooled HIV prevalence amongst MSM at about 30%. Next slide, please. So I'm not going to go over what is event-driven PrEP, as I think Michelle has given us all of that background, quite eloquently and articulately. But just a reminder, it is the 2+1+1 dose that I'll be talking through now. Next slide, please. Thank you. So we are rolling out event-driven PrEP within the ORAN pop-in site. So pop-in is the name that we've provided or given to our key populations-friendly drop-in centers. We provide services for men who have sex with men and transgender women. These services are peer-led. And we're operational across 5 districts, so Ekurhuleni, eThekwini, Mngungundlovu, eThekwini, and Tshwane. So 4 of the 5 districts are substantially large with a population density, great population densities, as well as fairly large men who have sex with men communities therein. We provide a holistic package of services, a status neutral approach. So we provide PrEP, HIV treatment, TB and STI screening and treatment, as well as gender-affirming hormone therapy for transgender women. Next slide, please. Thank you. So looking at event-driven PrEP, although it has been endorsed and we've got lots of literature proving it to be safe and effective for a period of time, it's not currently rolled out across South Africa. So the PrEP regimens that are followed is the daily oral PrEP. So irrespective of your biological sex at birth, everybody gets given oral PrEP, daily oral PrEP. And so based on WHO endorsement and with CDC support and guidance, we commenced the introduction and rollout of event-driven PrEP across our 5 districts in April 2022. So we co-created materials. We didn't just randomly start rolling out the event-driven PrEP, but we started with the phased approach of collecting information from our clients, having focus group discussions, as well as with our staff members who are very active within the healthcare fields. And we started developing IEC materials, how to explain, how do you take the regimen, what's important to remember, what to look out for, etc. We also have a very large social media footprint and understanding that the bulk of our clients are younger, so the ages are between 18 and about 34. And so their preferred method of communication and information channel messaging is is digital media or social media. So we disseminated the information through social media, Instagram, we sent it out via our WhatsApp listservs, YouTube, and Twitter. So we also had, once we started the rollout, we started slowly across the sites by introducing our clients to event-driven PrEP. And this was also supported through a self-risk assessment survey or questionnaire that our clients conducted to determine if event-driven PrEP was a suitable option for them. We also conducted a knowledge, attitude, and perception survey, which was an online survey conducted across the 5 districts to assess their patients' knowledge and experience with event-driven PrEP. Next slide, please. Thank you. So the reason that we want to push event-driven PrEP, or get it onto the South African implementation platform, is because we understand and we've seen from experience that there are multiple factors impacting adherence to our daily oral PrEP. Participants, if they don't feel that they're at risk, clients, if they don't feel that they're at risk, they opt out of PrEP, or they start taking random doses here and there. And then, also our populations are fairly, well educated, and so they'll read stuff on the internet and then, make assumptions and perhaps take the regimen incorrectly. We also have a large contingent of men who have sex with men who may not want to be on continuous PrEP if they can plan their sex, or if they have infrequent planned casual sex, which is true for a lot of our older MSM. So as Michelle had indicated, ED PrEP is a suitable, safe and effective regimen option for men. And we need to understand whether ED PrEP, how well it will be accepted and understood and taken up by our population of men who have sex with men in South Africa. So the process, clinical guidance and working practice guidelines for event-driven PrEP, we developed those. So, as we go through the process of implementing event-driven PrEP, we actually have a toolkit comprising SOPs, guidelines, etc., as well as IEC materials on how to educate, inform, and consistently engage with your clients on event-driven PrEP. Our aim here is to inform programmatic routinization of event-driven PrEP within South Africa. Next slide, please. Thank you. So as mentioned earlier, the data sources that we use to inform the design of how we roll out event-driven PrEP comprise self-risk assessment. So we developed a self-risk assessment questionnaire, which we also validated using factor analysis to determine which are the best scale items to use. And this assessment is primarily used for patients to identify, what risk they face, and as well as for the clinician to determine if daily or event-driven PrEP is the most suitable regimen option. The CAP survey to assess knowledge, attitudes, and perceptions, as well as measure the impact of event-driven PrEP on social media content, outreach, and in-group sessions. And then we had focus group discussions with our M-groups. M-groups is MSM who come together once a month, and we then discuss relevant topics, whether it's related to healthcare, mental health, physical health, or anything that is currently on the agenda. So these focus group discussions were had with our men who have sex with men M-groups, and to gain a greater insight of how they're experiencing the regimen, questions that they're facing, out in the field, and concerns about drug interactions, etc., as well as getting advice from them on how to market the regimen effectively to other men who have sex with men. We also implemented a client satisfaction survey to understand how clients are experiencing the engagement of the clinicians and the counselors with them on the event-driven PrEP regimen. And then we have an ED PrEP enrollment database where we monitor and track closely our clients who are on the ED PrEP regimen with follow-ups and to determine if there are any seroconversions. Next slide, please. So our IEC materials comprise, we've got quite a few pamphlets, posters, materials, but we send them out primarily through social media. And then we also have Clinical Mondays, which is a live hosted session with a clinician or participants who will then talk more about their experiences or be subject matter experts on PrEP, and then speak more about event-driven PrEP as a suitable regimen. We also had an event-driven PrEP launch at one of our sites where, it was quite a large event within the community where we informed everybody that, this is a new regimen, that if you can plan sex and you can take your regimen 2 to 24 hours before sex, this is the regimen for you. Next slide, please. So we also developed, not that one. We also developed a couple of animations which we shared widely on social media, and we'll play the second one to you. The first one is also a video clip, but we'll play the second one for the interest of time. There's the sound. There's no sound. Essentially, the voiceover here, which you probably can't hear, is one of our clinicians talking through, the fun times that you can have, and then how to take your event-driven PrEP. So the cartoon graphic follows, once you've had your sexual interaction, you need to take your second dose 24 hours after taking the first dose, and then you need to take your last dose, the third dose, 24 hours after that dose. Great, thank you. Next slide, please. Thank you. We also developed event-driven PrEP starter packs, and we, after enrolling 1,300 men who have sex with men on event-driven PrEP and having assessed, understanding and acceptability of the regimen and the regimen, we developed ED PrEP starter packs. So these starter packs comprise a little pill box with 4 little boxes in it. So you get, we've got a sticker that says 2. In the one box, and you've got 2 little PrEP pills in there. Then you've got +1 and +1 on the remaining 2. So that is the 2 + 1 + 1. It is accompanied by an HIV self-screening test kit, directions and instructions for how to use the regimen, as well as the HIV screening test kit. And we handed these out at SA-AIDS, the SA-AIDS conference, as well as at nightclubs. And what we explain to uptakers of the starter packs is that, yes, we could do with this catchier name, thanks all. What we explain with uptakers of the starter pack is that, ideally you should be testing before you take event-driven PrEP. If you test positive, do not take the PrEP. You would then need to contact us. So we give our contact details in the little package so that we can commence you on antiretrovirals. But we reinforce the need to do the HIV self-screening before you take the ED PrEP. And then once, if you're interested in ED PrEP, drop into one of our sites and we will get you started on the regimen. So the purpose of this is to promote awareness and uptake of event-driven PrEP amongst men who have sex with men as a safe alternative option for those who would be eligible for the regimen. Next slide, please. Thank you. So I'm quickly going to run through the results of what we have experienced here at Aurum Poppin sites. So cumulatively, we've got, sorry, there's things popping up here. Cumulatively, we've got quite a substantial number of clients on event-driven PrEP. So sorry, I can't see the bottom part. I'm just pulling mine up. So the little red bar is the number of clients who were offered event-driven PrEP. The orange bar next to that is the number of clients screened for event-driven PrEP. And then the little green bar next to that is the number of clients who were initiated on event-driven PrEP. So we've got the dark green bar is the number of clients initiated. So the bulk of our event-driven PrEP initiations has occurred in Ihlanzeni District Municipality, which is in the Mpumalanga province, them and Ekurhuleni. So Ihlanzeni is marked by a fairly rural population, whereas Ekurhuleni is a very urbanized population. So we're not seeing any differences in, urbanicity in uptake of event-driven PrEP. We've had no seroconversions on the event-driven PrEP regimen. So essentially that we've had 3 seroconversions, but those were on the daily PrEP options. Next slide, please. So looking at the CAP survey, the overall knowledge of event-driven PrEP was very good at 72% answering questions correctly. So the sample size, was 295 clients. And of the 295, 72% had answered the questions correctly about understanding the event-driven PrEP regimen. Next slide, please. So looking at ED-PrEP knowledge according to districts, we have poor knowledge, predominantly, this is percentages, within the eThekwini municipality, where 50% of them had answered questions incorrectly about event-driven PrEP. And then the Ekurhuleni, as mentioned previously, has demonstrated really good knowledge with about 50% of their participants answering questions correctly about event-driven PrEP. So the disparity across the districts aren't that substantial, with the exception of eThekwini, where there was also about 30% who demonstrated a fair knowledge of event-driven PrEP. Next slide, please. So looking at overall event-driven PrEP attitudes and perceptions across the 5 districts, of the 295 participants, there were a large majority of them had demonstrated a positive disposition or attitude towards event-driven PrEP, indicating that they feel that it is safe and that it is not necessarily stigmatizing to be taking event-driven PrEP, and that the option avails choice to men to control when and how they want to take their PrEP. Next slide, please. So looking at the summary of the CAP survey, the 18 to 24-year-olds revealed the poorest knowledge of event-driven PrEP, which is quite alarming because that is exactly the age category that we want to delve into. There was no significant association between age and knowledge regarding event-driven PrEP, but we did find a statistical significance between district and knowledge regarding event-driven PrEP, as I had just shown between eThekwini and Ekurhuleni. The 18 to 24-year-olds also had a fairly negative attitude regarding event-driven PrEP compared to the other age categories. We found statistical significance in sexual orientation regarding ED-PrEP. So the greatest positive attitudes were with participants who had male and female sexual partners, as well as those men who had mainly female sexual partners. We also found statistical significance between education level and attitude, with interestingly and quite counterintuitively, those with a high school or diploma education level having a negative attitude towards event-driven PrEP. For the last point, we did, actually that's the last point. Next slide, please. So looking at an additional summary on the CAP survey, perceived risk of acquiring HIV. So, we asked participants to rate their risk for acquiring HIV, and we found statistical significance for those rating themselves at low or low to medium risk, and a high likelihood of recommending event-driven PrEP. Predictors of who would use event-driven PrEP or their likelihood to recommend event-driven PrEP, the predictors of self-risk assessment, as well as socio-demographic variables were not good predictors, yet a younger age and higher education level were good predictors, especially those amongst university level education. Those were good predictors of recommending event-driven PrEP. Next slide, please. Our qualitative interviews, I'm just going to run over these very quickly. These are the focus group discussions that we've had. So along the themes that emerged, we've had event-driven PrEP acceptability, where participants had said that they thought it's a great initiation and mitigation towards HIV and promotes regular testing. And then the first time I heard about PrEP, I was very interested. I do try to use condoms during sex, but essentially the longer story is that they don't know, if their partner uses condoms. So this individual thought that it's a good HIV prevention strategy. Next slide, please. The second theme was ED PrEP use decision-making. So the majority of the clients expressed that their decision to use event-driven PrEP was influenced by information that they received from the nurses at the sites, and expressed that the nurse reassured them about the convenience of the regimen and the safety and efficacy in preventing HIV. Next slide, please. Regarding ED PrEP adherence, the clients commented that they make use of reminders such as an alarm to help them to remember when to take the next doses, and to also in taking the meds simultaneously with other meds such as vitamins, which would help with the adherence of the PrEP regimen. Next slide, please. Our clients were confident to share information about event-driven PrEP with peers and partners, which was actually a very interesting outcome from these focus group discussions, because usually we find that a lot of our clients say that, they don't want to disclose that they're on PrEP because of the stigma associated with it, and the notion that they are promiscuous. So for the focus group participants, they indicated that they were confident to tell their partners and families and friends about event-driven PrEP, as a really good regimen, as an alternative regimen to daily oral PrEP. Next slide, please. Our client satisfaction survey. So we had quite a few participants who completed the satisfaction survey about event-driven PrEP. 79% of them, so 66, indicated they were very satisfied with the information about event-driven PrEP. So not the regimen itself, but about getting information about the regimen, how to use it, and any concerns or side effects that they may experience. Next slide, please. So these are some quotes regarding their satisfaction with the general information that they received. So the information received was amazing. They were educated. I was not aware that there's prevention for the virus, which is a big alarm. And the person who was assisting me with the event-driven PrEP was very informed about the information, and she gave me sufficient information. 2 + 1 + 1 is great for HIV prevention. So this just goes back to the materials that we've developed using a co-creation modality, ensuring that the information and the methods of the information transfer, so via social media, WhatsApp, the digital animations, etc., resonates with the primary target audience. Next slide, please. So to the client satisfaction survey, 82 of the clients would recommend event-driven PrEP. Only 2 of them indicated that they would not recommend event-driven PrEP. Next slide, please. And then satisfaction with continuing to receive or continue with the PrEP regimen. 59 indicated that they were very satisfied and that they will continue, and 19 indicated that they were satisfied. There were no other responses here. Next slide, please. So our conclusion relates to the engagement with men who have sex with men about their experiences in using event-driven PrEP, as well as understanding or exploring their understanding and confidence in using the regimen. It's essential that when you roll out a new modality, that you understand what is the confidence level, within the use of that modality. And if, as public health officials, what is our role? Where are the gaps that we need to fill to promote confidence and satisfaction with a specific prevention modality? So an essential component of delivering event-driven PrEP, it's not just about simply giving out the regimen and saying, remember 2 + 1 + 1, and giving written instruction, but it's important that you understand how your participants or your clients want to receive that information. Written instructions, we find, does not necessarily work for everybody. It's not related to literacy levels, not as many would think. It's more related to convenience of access and, you know, making sure that the material resonates with your target audience. So the most critical component of rolling out the event-driven PrEP regimen is education, education, education. And not simply following one modality of education, but having a multitude of messages and message channels and messengers in relaying that message effectively on how to use your regimen. As a suitable, safe, and proven effective regimen, I would like to close in saying that it is incumbent upon us as public health officials to ensure that the regimen option is made available to all eligible candidates. So as Michelle had indicated in her presentation, to all cisgender men, where event-driven PrEP would make a marked difference to those individuals who would then opt in for PrEP versus those individuals who simply do not want to take daily oral PrEP if they are not exposed to frequent, frequent unplanned sex. Thank you.
Excellent.
To the moderator. Thanks.
Yeah. Thank you. Thank you so much, Jacqueline, for a very, very insightful presentation. I really like that you've done very robust monitoring and evaluation of the program, and the results are going to inform quite a bit of the things that the countries that are actually joining. I also like the demand generation that you actually put. Awareness and demand generation are very critical to the success of any intervention. So I like that you've put that right at the center of your work. I want to welcome Featherstone Magoja from Zambia to give us the Zambia experience. There are quite a number of questions that are coming up. So Featherstone, take it away, and then we shall be able to get into the questions as for greater understanding. Thank you.
Yeah, thank you, Lucy. Good morning. Good afternoon to everyone on the call. Just want to I think, give our perspective as Zambia. Quite a lot to learn from South Africa, who have already gone ahead of us. You can tell that I think there is a lot to learn, even as Zambia, as we are trying to introduce AD PrEP. So what we're going to showcase as Zambia is purely maybe how we are trying to navigate around the conversations on AD PrEP. Next slide, please. Yeah, so this gives us just a perspective of where we're coming from in terms of implementing oral PrEP in Zambia. And so I think from 2015, when WHO gave that guidance, in Zambia, there was a task force that was formed in 2017 just to develop the policy and to provide guidance around PrEP implementation. And we see that in 2019, a pilot PrEP implementation was done by UMB and UTH. And this was just around 3 sites in Lusaka and Livingstone, the southern part of Zambia. And so 2018, we saw oral PrEP being included in the consolidated ART prevention and treatment guidelines. And we have seen that the same year later, I think we had the same implementation framework around PrEP. And then now we continue to scale up to many other sites, to 728 facilities, which is quite, I think, a great milestone. Next slide, please. Yeah, so how and where are we implementing? So just to indicate that, like in my earlier preamble, that Zambia is yet to begin implementation of AD PrEP. But however, what is it that we have done? Just to try and I think have the conversation on the table. So when WHO gave guidance last year around the PrEP guidelines, we did convene as a task force in Zambia to have the conversation, to discuss what was new around oral PrEP, to discuss issues around PrEP at the time, and PrEP was one of the agenda items that we had discussed on. After that particular PrEP task force meeting, of course, at that moment, we were just learning to review what WHO had done. We deferred the conversations to the next meeting. After, in the next meeting, we met again to re-evaluate and look at whether PrEP could be included in our guidelines in Zambia. Just to let everyone know that in Zambia at the moment, we are revising our PrEP guidelines. And so the conversations around PrEP has continued to evolve within our meetings. The Ministry of Health has actually guided in terms of what Zambia needs to include when it comes to the PrEP guidelines. This is so because I think Zambia, as you are aware, is a quite religious country. And so whenever you are introducing any new technologies, you really need to continue to look at that aspect of it and the social side of it. And so in developing the guidelines, PrEP, actually conversations has evolved, and we have just resolved to say that we are not going to flat out include it in the guidelines. But however, I think as implementation of CAB and oral PrEP continues, we see how it can actually be introduced to take some lessons in some sites where CAB will be implemented. And so and so when it comes to really maybe considerations of the sites that maybe PrEP can be introduced, just the way it was when we rolled out oral PrEP in Zambia. We started with fewer sites and then had to scale up. And so probably we might be able to now include PrEP in the few sites that are going to implement CAB. And from there on, we were going to be able to take some lessons, which we can be able to see whether we need to scale up or in probably we modify our guidelines going forward. Next slide. So some of the challenges and lessons learned around, I think, PrEP as we are having this conversation on the table. I think one of the conversations is around the packaging. Already, I think we have had issues around or concerns around how the packaging just for oral PrEP. And so for PrEP, we've been now having conversations to say, how is it going to be packaged? We have also, I think, been having issues around where are we going to place it? Can we place it in the private sector? Can we place it in the, those pharmacies that are dotted around? Can we place it within the PrEP sites and so on and so forth? And so when it comes to packaging, are we going to just package it to say 2+1+1? And who is going to do this for us? How is the cost looking like? And so these conversations, I think, around packaging has been one of the things that we've been discussing. And then when it comes to defining, I think, the target group, when we started oral PrEP, initially oral PrEP, I think it was for the key population. And so the lessons that we learned was that as we were scaling up, there was a lot of stigma and discrimination attached to oral PrEP. And so that affected the uptake actually to the general population. Now for PrEP, of course, yes, from the guidelines, as we saw from WHO, that it is for men who have sex with men, and now we are saying men in general. So in our conversations, we were having it that I think probably we should just remain open and just not define that PrEP is just for MSMs, but however, to just say this is a product that we need to target men. So defining the target, I think, is an issue just to avoid discrimination in future as we are going to scale up. And then as earlier indicated, Zambia is a highly religious country. So how are we going to craft the messages around ED PrEP in order not to be seen to reinforce perceived promiscuity or promoting promiscuity, as it were? So this is a very crucial part, I think, of scaling up or introducing ED PrEP in Zambia. So we are having now, I think, this conversation to make sure that we craft the messages to be very clear that I think this is an option that can be able to be very helpful and add it to the toolkit of HIV prevention portfolio, and not necessarily that I think it is increasing promiscuity. Next slide, please. So when it comes to the innovations, I think because of the sensitivity around ED PrEP, so initially the task force had considered to say, maybe let's include the guidelines. That graph that you saw that WHO was actually put. But however, we got guidance to say, I think let's not include that graph in the guidelines. So probably within the narrative, you just mentioned that I think ED PrEP is one of the products or one of the interventions that are used to target men, just to, I think, manage those issues. And then as well, one of the innovations is perhaps maybe as we start implementation of CAB in those particular demonstration sites, ED PrEP can be able to be introduced there just to take some lessons, and thereafter maybe reevaluate and see what the way forward will look like. Then the other innovation is actually, I think, in the guidelines, not necessarily putting that ED PrEP is for MSMs. I think in one of our narrations, we even said that ED PrEP actually will be for vulnerable populations. So the idea was that we should not come out as to put it to say MSM because of the sensitivity and because of the discrimination and criminality of clients that or potential clients that are going to be on ED PrEP. So we need to be innovative on how we actually define the target group, especially in our setting here in Zambia. And so then the other innovation is perhaps considering maybe including ED PrEP in the safe spaces, because a safe space is where I think it can be provided without much maybe discrimination, from the general population or from the various groups. And so this one, as maybe as a community DSD model, probably ED PrEP in there, because it's a safe space, it can be able to be introduced in there. Next slide, please. Yeah, so you can see that I think from the Zambia's perspective, we are at a stage where we are just having the conversations and we haven't yet finalized our guidelines. And so it is good really to share a platform with South Africa that have gone ahead of us and that we can take lessons even as we navigate on also including ED PrEP in our guidelines in Zambia. Thank you, Lucy.
Great. Thank you so much, Featherstone, for your presentation and for the considerations that Zambia is making in terms of rolling out ED PrEP. I see we have quite a number of questions and some have been answered on the chat. So continue to put your questions on the chat and I will ask our presenters just to be ready to answer these questions. I'll kindly just read out some of them, and I think they were directed to the Arum Institute. Jacqueline, one of the questions is, do you do active follow-up of clients on ED PrEP, or is it self-reporting? And then how do you document continuity of the ED PrEP? And did you develop separate tools for ED PrEP as well as for oral daily PrEP, or is it just one tool? Maybe Jacqueline, you can answer those questions just to start us off. Jacqueline, maybe you can unmute. because this was very, very specific, I think, to your implementation and to your experience. As we wait for her to unmute, I think that there's a question regarding, these are very specific to the Arum Institute. There's a question also that if I take 2 pills on the first day, am I required to take 1 pill each the second and third day to complete the dosage? My question is, what if I take 2 pills on the first day, at least 2 hours before sex? On the second day, I decide to have sex, let's say at 12 noon. My question is, should I take 2 pills at 10 a.m. before having sex at 12 noon, or should I just take 1 pill since I already took 2 pills the previous day? I think this is still around dosage and when and how to take it. Maybe Michelle, if you're there, you can answer this.
No, I'm here. I just wanted to check if Heather Marie Schmidt is still on the line. Because if she is, I'd like to ask her to respond to this. Heather Marie, are you available to respond to this?
Hi, everyone. Yes.
Go ahead.
So there's a couple of things here, and it relates to a few of the other questions. For this one specifically, you can, as I wrote in the chat, you can absolutely continue to have sex. You do not need to abstain, but you should continue to take 1 dose of PrEP per day until 2 days after the last time that you had sex or you had condomless sex. This advice specifically refers to cisgender men and transgender women who are taking who are not taking gender-affirming hormones. But while I have the floor, there are a number of questions just to clarify what event-driven PrEP actually means. And Michelle showed the tables and everything, so I'll just reiterate some of that, if that's okay. The terminology for ED PrEP is a little bit outdated, and I think it's causing a little bit of confusion for people. The WHO guidance now focuses very much on how do you start and how do you stop PrEP. And so our guidance is that men can use or do use what we call an event-driven dosing regimen to start and stop. But really, one of the things that I want to say is that 211 is not the same as event-driven PrEP. 211 is event-driven PrEP for one, or the dosing regimen for one event. You can use event-driven PrEP for multiple events or for daily. So really, we're starting to move away from that because I think it's been a bit confusing to people. So in practice, what this means is that all men start and stop PrEP exactly the same way. If there is one event, or if you are having multiple events, so let's say Friday, Saturday, Sunday, or you wanted to take PrEP daily, you still start with 2 pills, 2 to 24 hours before the first sex, continue with 1 dose per day until 2 days after the last time that you have sex. This is for men. And I want to highlight that women and other groups, people who inject drugs, trans women who are taking gender-affirming hormones can also do PrEP for a single weekend or for a single event. It's just that the dosing to start and stop is a lot more complicated. So you need to take it for 7 days before your first exposure. You take it for as long as you're being exposed, and then 7 days to stop, which is not quite as practical or easy as it is for cisgender men, for example.
Excellent. Thank you so much, Heather Marie, for giving us those clarifications. I think very important. I had a few questions for you, Jacqueline, now that you're back. One of the questions is, do you do active follow-up of clients on ED PrEP, or is it self-reporting? Another question is, how do you document continuity on ED PrEP, and whether you use separate tools for ED PrEP and oral daily PrEP, or whether you are just using one tool. maybe just to start us off, I think around the tracking and monitoring of clients and how it's being done.
Thank you very much, Lucy. So it's an active follow-up. We don't, dispense the PrEP and then let the client come back whenever they need. So we dispense the PrEP, and in their client record, we would, they would tell us, how long they estimate the PrEP, because they get a full bottle dose, how long they think that would last them based on the number of anticipated planned sex acts that they would have within the next month. So we contact the patients again after a month to see how they're doing, how their PrEP supply is, and we try and make sure, to remind them that, when they have it's 3 doses left, they need to come back to us to dispense more PrEP. Your next question was related to the tools that we use. That was your third question. So the tools are very similar for event-driven PrEP and daily oral PrEP. The client records, etc., the follow-up process, even the self-risk assessment questionnaire is the same for us to determine whether it's ED PrEP or daily PrEP, which would be the most suitable option. There's no real difference. The only difference comes in the follow-up cycle, how soon and how quickly we follow them up, as well as in our IEC materials. Yeah.
Excellent. Still some more questions for you, Jacqueline. So kindly there, I think your program is you've done quite a bit of work, so there are quite a number of questions. Another question is, how was HIV testing scheduled? And can you confirm whether, in your settings, ED PrEP, is it provided in pharmacies, private clinics, and drug shops? And how much of PrEP do you dispense at any given time if it's for ED PrEP?
Great questions. Thank you. Thank you, Lucy. So your first question, your first question related
is about HIV testing and how it is scheduled.
Yeah. So we follow the exact guidelines of WHO. So as the patient comes in our status neutral clinics, they would receive an HIV test. If they test negative, we would then explain to them the option of PrEP. And so you've got your 2 regimens, daily or event-driven. They will do the self-risk assessment questionnaire. We would, coach them through what they think would be the best regimen. And then we dispense. So one of your other questions were how much PrEP do we dispense? We dispense a full 30-day cycle. So they go home with the bottle. And then we do ask them to come back to the clinic 1 month later to test again with us, because we may have initiated them, within the acute infection stage. So we require them to come back month 1 after ED PrEP initiation, and then thereafter we dispense HIV self-screening test kits, to them, and we ask them to come back into the clinic every 3 months to do a provider-initiated test. For the question related to the pharmacies, the private pharmacies, the private pharmacies currently in South Africa are not providing event-driven PrEP. Yeah. So one of the options, one of the modalities that we roll out as part of our model is called e-pharmacy, which is a courier-based clinical delivery model for PrEP. So anywhere in the country, you can sign up onto our e-pharmacy platform, and we will dispense event-driven PrEP or daily oral PrEP, provided that you meet the requirements and the eligibility criteria, and then from there onwards you would get the drugs couriered to you. But the short answer is the private pharmacies do not dispense event-driven PrEP yet. And there was another question.
So the next question is around, given that you're giving clients 30-day dosage to go home with, so education is really critical. So when you say, the question is, when you say education, is it specific to ED PrEP, or is it just the broader package of, oral PrEP? Because I believe that for the client to be able to understand or the ED PrEP, that there's some information that's required. So how do you differentiate information for oral PrEP, daily PrEP, and also for ED PrEP?
Great question, thank you. So for the client that goes home with the event-driven PrEP, they'll get their written instructions, but they will also get, we've got case facilitators on staff. So we have a list of who our PrEP clients are on event-driven PrEP, and then they would get the messaging about how to use the event-driven PrEP via WhatsApp. And so, you know, they actually have it with them wherever they go on their phone, because we all know we're hardly ever separated from our phones. So the daily oral PrEP clients, they don't get as much interaction, shall I say, because for them, the education for the regimen is far simpler. Just take your pill every day. And so, you know, when I say education, I mean event-driven PrEP, because, you know, the PrEP regimen, the event-driven PrEP regimen is sometimes a little confusing, especially if you have multiple sex acts before you finish the, you know, the last +1 dose. Then the questions are, now, do I take another, you know, double dose? When do I finish the +1, etc.? So, for, you know, for those reasons, we follow a far closer and more targeted education strategy for patients who are on event-driven PrEP.
Excellent. I think this next question goes to Zambia, to Featherstone. Sorry, I've lost it. Looking at the context of Zambia and the most countries, including Tanzania, how, in terms of contextualizing the approach, it is very key. But what about M&E, and will it be part of the national data? What are you thinking? The second question is, what strategies have you put in place, or do you consider putting in place to ensure continued and correct use of other prevention methods, such as condoms, as people are taking ED PrEP? Yeah. So what do you, Featherstone?
Okay, thank you, Lucy, and thank you for that question. Yeah, so for Zambia, like I indicated, that number one, ED PrEP will not be included in the guidelines, and so it will not be implemented as it were. And so what the ministry has guided is that from those sites where CAB introduction will be rolled out in October, November, if an implementing partner desires that maybe they want to have an understanding around ED PrEP, then they can write a protocol to the ministry, and then the ministry is going to give an approval and further guidance on how this is going to be done. And so data in that particular setting, then I think will be managed and guided accordingly. So I think that's the approach at the moment. Then the other question was around, what was the other question?
Around strategies that you have put in place just to ensure that other prevention
combination prevention. Yeah. So so the word that actually we are using currently in Zambia, even as we promote PrEP, is combination prevention. So PrEP has to be used in combination with other methods. And so, because I think we need to be very careful, because the moment that people think that once you take PrEP, then that's the bullet, that's the one that gives you, you know, the full protection. And yet we have other STIs that come that need to be protected as well. We have hepatitis B that is on the table as well. So as we package the messages, I think we are promoting combination prevention, and I think that's how the messages are going out.
Excellent. I think there are two more questions, and they can be answered by either Featherstone or Jacqueline. And I think that one is regarding advocacy with the religious leaders who oppose or object PrEP. How do you advocate for South Africa? How have you done it so that there is acceptance? And for Zambia, what do you plan to do? Because religious leaders will come up. Do you have a plan to address that?
Thank you, Lucy. So I just responded actually on the chat. We engage with faith-based organizations and their leaders, in general, just for them to promote uptake of HIV testing, as well as to foster a tolerant and accepting environment for our key populations, namely men who have sex with men and transgender women. In our engagements with faith-based organizations, we aim to explain that PrEP is no different to condoms, essentially, and condoms are widely promoted, by most religious organizations. So we go through the process of, explaining that HIV incidence is still on the increase. And so if condoms was the single most effective method, we wouldn't be, sitting where we are today. We understand that people don't use condoms. And so, we take them through the process of, sometimes condoms aren't available. Like in South Africa, we've had en masse stockouts of condoms across the country. And PrEP provides an option, especially for serodiscordant couples, people who are in committed relationships, who have serodiscordancy. So it provides options for large members of the congregation where condoms may not necessarily be a consistent option for them. I have to say, in South Africa, we haven't experienced much of the stigma or narrative around PrEP promotes promiscuity. And I think it's because we did a really effective job in shutting down statements made years ago that condoms promote promiscuity. So now people understand that PrEP does not promote promiscuity any more than condoms do. Over.
Excellent. Featherstone, do you have any thoughts on that? And how you're working with religious leaders?
Yeah, so I think being consistent with coming where we're, when treatment, for example, for HIV was introduced, I think those conversations and those suggestions were on the table, where people thought that even treatment was actually going to promote further promiscuity. And so over the years, I think people have shifted and have realized that I think that is offering a solution and not the other way around. And so PrEP being one of the ARV-based, I think, biomedical prevention methods, I think emanates from the treatment side. And so as we are packaging the messages around treatment as prevention, as well, we draw, I think, strength from there and say PrEP as well, I think, is able to offer that support in that line. And so I think just like what Jacqueline has said, I think further engagement with the religious leaders as well, I think, is very, very key. And so that in itself, I think when we engage them and we share with them, I think, what these interventions are, they are able to really, I think, stand and say, I think, such biomedical prevention methods are still very, very helpful. But I think it's messaging and being consistent from where we're coming from. Thank you.
Thank you. Thank you so much. I think I have just maybe two other questions that maybe I require you to address, because this is shedding a lot of light. For Jacqueline and Featherstone, how do you record in tools if someone is transitioning from ED PrEP to daily oral PrEP, or vice versa, from daily oral PrEP to ED PrEP? How is that captured in your data? And I think maybe to Jackie, because you're actively implementing.
Great, thank you, Lucy. Thank you for the question. We do advise our clients when we commence them on either PrEP regimen that they are able to switch, because what is of primary notation is that a person's sexual risk fluctuates, and we've seen that is quite substantial. That fluctuation is quite substantial amongst men who have sex with men. So we explain to them that, as your risk profile changes, you have the option of switching between event-driven PrEP or daily PrEP, or you can just stop PrEP altogether. And how we capture that is when we give them a call, the patient's on event-driven PrEP, we would then ask them, how are you finding event-driven PrEP? How many doses do you have left? and then we will ask them, have you switched to a daily regimen? We actually have a dashboard where we collect all of the switches, so as patients switch and, they've moved to daily PrEP, we ask them to come back in to ensure that they've got another supply, or as a daily PrEP person comes in for their routine HIV testing, we would ask them, have you switched to event-driven PrEP? And so, we actually capture it as part of our clinical stationery, which goes onto our electronic dashboard. So we do keep track of those, yes.
Excellent. Again, final ones. Sean Malone is asking, what are your thoughts on the use of the term planned sex? I think that was in your presentation. What are your thoughts, and is it really a term we should be using? Does it, what does it mean for the populations that you're reaching? Is it something they do? Because I think one of the things that we've seen is that people don't plan. It's maybe done even in marriage. It's usually, sex is usually unplanned. So your thoughts on that particular term?
Thank you, Lucy. That's the best thing about sex, is that it is sometimes unplanned. So we use the words expected or anticipated with our clients. We don't always use the words planned, but we say, when you anticipate having sex or when you're expecting sex, take your tablets, take your event-driven PrEP, the double dose 2 to 24 hours before. So those are the terms that we use, because planned is not something that you kind of it's link in with sex. Yes.
Excellent, thank you. I see in the interest of time, we had 1.5 hours, but I just want to call Chris Obermeyer to just make a comment. There's a comment he's made on the chat. Chris, sorry to call you out, but if you have some parting words you can share, and then Heather Marie will also give us some parting comments before I invite Kerry to give us closing remarks.
Yeah, thank you so much. I'm just reflecting on the conversations around monitoring people switching from an ED regimen to a daily regimen. And I think it's important to recognize that, as I think WHO has really emphasized, it's not so much it's really a different way of using the same oral PrEP. And I think the emphasis should maybe not be on monitoring how many times did I use event-driven PrEP versus daily PrEP, and at what point does event-driven PrEP become daily PrEP? Is it after 3 days? Is it after 10 days? But more about helping clients to pick strategies that fit for their lives and making sure that they're empowered in order to use PrEP in a way that is effective for them and reduces their likelihood of getting HIV.
Excellent, thank you, Chris. Heather Marie?
Sure, I would wholeheartedly endorse Chris's statement around empowering people who may benefit from PrEP to use it in the way that will help them the most. And so this is where our guidance around starting and stopping PrEP, it's really actually to simplify it. I know it sounds like it's more confusing, but actually the idea is to make it much, much easier for people to be able to use it during periods of potential exposure. And so this relates to the M&E, where really we're not looking at whether somebody is using event-driven or daily dosing, we're looking at effective use. So are people using PrEP during periods where they're likely to be exposed to HIV? And are they covering those periods with sufficient PrEP? Because taking daily PrEP during periods of no exposure, I mean, people don't necessarily need to do that. Perhaps they want to do it because sex is unpredictable for other reasons, for personal reasons, but really what we want to focus on here is effective use of PrEP. So that's probably the point I'll leave everybody on.
That's key, the effective use of PrEP and not just using PrEP. I have a question for Michelle. There's a question here. Is there data to permit better modeling of the risk-benefit ratio of ED PrEP with respect to drug resistance?
Just put my video on here. So as far as I'm aware, no, there isn't. However, the risks are very low at promoting drug resistance with ED PrEP. And with oral daily PrEP, effective use is the key in reducing drug resistance.
Yeah.
So by effective use, meaning taking the PrEP when at risk for acquiring HIV.
Excellent. So thank you so much, our presenters, Michelle, Featherstone, Jacqueline, very insightful presentations. And I want to invite Kerry Mangold, our program director, to just give us some closing remarks. We'll be able to share the presentations with everyone who's participated or registered on this webinar. Welcome, Kerry.
Great, thank you so much, Lucy. And yeah, thank you for thanking our speakers already. Lucy, I want to also thank you, and I want to thank Karabo and the SSLN team for pulling together this webinar and also executing it really well in response to a call from our champions. To all the number of SSLN champions on the line, I want to thank you for asking for this learning event and then showing up and also engaging so actively in the audience. I think what we've seen is that over the last 8 years, the PrEP landscape has advanced and changed. And so that really means that learning also needs to be continuous. And also that we need to learn not only from best practice, but also from mistakes, from other people's lessons, and from some of the small successes in the process of introducing and rolling out PrEP in the various countries in Africa. I think we know there are very different timelines and very different contexts, some really challenging contexts, in fact, where PrEP rollout is constrained or restricted by criminalized environments or environments where there's high levels of stigma or by very conservative religious views. But also we know that there are some stories of success, and we've seen some examples where people have overcome difficulties. And I think the presentations today from South Africa and from Zambia really show us that. Also, from the number of people on the call, it's very clear to me that there's a whole lot of allies linked to the SSLN who can be drawn on if you're considering event-driven PrEP in your country and you want to learn from others. So I think what I just want to say as we close is to everybody on the call, please allow the SSLN to continue linking you to others in this network who have different experiences and different expertise, those who can relate to you, who can support you, who can help problem solve and share some technical advisory with you. I think this is our commitment as the SSLN and the beauty of the South-to-South learning platform. So this webinar is not the end of the discussion, but rather it's the start of a longer term engagement with everybody here. And so I would like to ask all of the champions, if you still have unanswered questions, if you would like follow-up discussions, if you would like additional support on this particular topic, please reach out to your country engagement leads. You know who they are, or myself or anybody on this call for that matter. So I think that's what I will close with, just to thank you once again and to officially close the webinar. So thank you, everybody, and farewell.
Thank you, everyone, and thank you. Bye.